So we are very fortunate to have Dr. Steve Benirschke with us today. He fits under the cliche of needs no introduction. Steve is husband and father to three, and in addition to that, trained in orthopedic surgery in Cleveland, and from there went to University of Washington, where he was inspired by his mentors to try to answer questions that hadn't been answered. And over the subsequent 3 decades, 3+ decades, has been literally changed the practice of hind-foot trauma and foot and ankle trauma, changed the clinical practice of it, changed the thinking about it, and impacted one small area of what we do in a way that very few people have. He has published on that. I don't need to recite his CV, but from the beginning of his career, where he was inspired by his mentors, perhaps most importantly now, he is the mentor and inspiration to an entire generation of trauma surgeons. He is going to talk to us today about what he knows best on the topic of ankle and foot trauma. The Tsunami is here. We are very appreciative of how generous Steve has been with his time for the last 36 hours and for the rest of the day today. Steve, thank you.
Thanks, Thomas. Well, thank you very much for that kind introduction. You have to realize, for you residents, when I was the R2 level, I had no really idea what I was going to do, and it took a pivotal visit by. Yeah.
I don't mean to interrupt you, but this thing is
hitting something.
Bouncing. I'm having a problem.
Okay.
Try that.
Okay. So I was really unclear about what my path would take, and so it was pivotal for me when I was in R2 because Ted Hansen, who is one of my mentors, like my dad, but a mentor of mine, who came to Cleveland to talk about something that we had never seen, had no clue about, and that was about iamnialing the femur. And in the ensuing couple of days that he was in Cleveland, he finished the final day, and that was a pivotal moment for me. Was I was in the back of the room because all the attendings were sitting in the front. And he then paused and said, you know, I'd like to talk to you about something that one of my medical students has been looking at, and I just want to see what you all think about this. And that's the operative treatment of open ankle fractures. And there was like a silence in the room because, first of all, we weren't putting metal in open wounds. Second, we weren't fixing ankle fractures the way he was talking about it. And in the back of the room, I was next to a buddy of mine who also went into trauma, Jack Wilbur. And I turned to him, and I'll never forget this. I said, you know, Jack, this guy is either crazy or he's crazy smart, and we should go out there, because it was totally the antithesis of what I trained, and I thought I had good training. So I'm going to give you sort of a whirlwind tour of why things evolved, and I do have to thank Ted, because he never really told me that you couldn't do something. He didn't necessarily tell me how to do it, but he did say, this is a problem, figure it out, because there isn't a good answer for the way things are done now, so it can't be much worse than it already is, so why don't you see if you can make it better. So we'll talk about this. I think I use the term tsunami not to be incendiary, but really to describe what is happening in trauma in general, not in this country only, but worldwide, and that is what a tsunami really is, by definition, is an arrival or occurrence of something in overwhelming quantities around us. And that is really what's happening now, and we'll finish off with some statistics, but the big issue is this is not going away, and unfortunately, as I was telling residents yesterday, it's not only not going away, but it's becoming more frequent and more complex. When I started, it was actually 35 years ago now, when I started, the injuries that we would see were never treated because the patient died. And I remember, I will admit that there were times when there was basically a warm autopsy going on in the OR, and somebody was pumping on the chest or opening the belly, and somebody had taken a radiograph of maybe one of the lower extremities, and I was secretly saying to myself, well, I hope they don't survive, because if they do, I don't know what to do with that if that patient survives. And so now it's the antithesis. Because when I got to Harvard, it was a pretty small hospital. Ironically, the heliport, which is shown here, wasn't next to the ER bay, so the patients had to fly in from all over and then have a 150-yard ambulance ride to the emergency room because there was no facility to get them into the ER bay.
Keep talking to see if we can troubleshoot that mic.
Oh, okay. Can you all hear me? As I admonished Thomas, you guys are supplying the second largest land mass surface area in the country. We're not by virtue of, just by virtue of the land mass of Alaska, so Thomas wants to annex Alaska and hopefully increase your catchment. But we would get these injuries, and it was fortuitous for us because all the injuries would come to us, nobody else would take them. It took Trunky to go to Oregon to start a trauma center in Portland, but prior to that, even things came from Oregon to us because there was no level 1 north of San Francisco. And so they would come by various means. We would get them by fixed wing, helicopter, ground transport, and it was a phenomenon that things would come directly to our hospital. They wouldn't pass any other hospital. That's very different now, as you all know, because it's a change in time. And it's really dramatically improved in the sense that we have done much better in the way of caring for patients that are dramatically injured compared to when we first started. And we've been in competition with Europe. I think that some of the things you're going to see will illustrate some of the ways that we've maybe moved ahead, because the defenses we have are a myriad now. I was fortunate enough to do a sabbatical for a year in New Zealand, and there was a big awareness in that country about what is the cause of many of the accidents, and that is literally awareness of where cars are, where people are, and recognizing the importance of speed limits and signs and so forth. Injury prevention, we all know, I think most of us wear a seatbelt at this point. In Seattle, there was a law passed that all bicyclists needed to wear helmets. That was a law that was passed that I think was helpful. And then around 1995, automobiles came along that had at least a single driver airbag or a passenger airbag. But really prior to that time, many of the things we saw were really the lower two, falls from sports or work-related injuries, were a big number of the osseous lower extremity injuries. And then what rose to the top was the motor vehicle. By far now it's the principal vehicle, truly, by which people are injured. Our survival is better because we are doing a better job with cars in general. We're doing a better job with transporting patients and resuscitating patients with things that came along the same time, the pulse oximeter that didn't exist when I was in training. And then expeditious treatment, which we were able to do because the patients were cared for. I talk about the 80s as the period of time where we made some macro improvements in design of implants. I was fortunate in Seattle because Ted Hansen and his predecessor were basically educated by Kuncher in using IM nails for the femur, and so there was already a pre-existing sort of push toward interventional nailing, which we didn't have in many areas of the country. And plates and screws were something that also had evolved and were being used on a regular basis. We didn't do that in our institution. And when I came, external fixation was just starting for the tibia, and unreamed nails weren't even on the horizon yet. They didn't exist. And so the nailing systems that ultimately came down the pike were really not supposed to be complicated. They were actually supposed to be simple. A resident should be able to put one in and not explode the femur. It should be done in a way that there weren't a lot of instruments. And this nailing device, which you see, is simple. It's percutaneous. We wrote a paper on it. It's by far, you can nail almost anything with that. Obviously, you can't do the top and bottom lesions, but it went away purely because industry decided they wanted something more expensive. And in fact, when they were phasing out this nail, we basically called all the various institutions around the country to send their nails to Seattle so we could keep using this until it no longer had the parts. Unfortunately, along with this, we had an issue related to fat embolism, which was largely caused by sometimes the injury, but many times by the reamer technology, and that was a problem in terms of managing patients with bilateral femur fractures, for example. And then we started looking with transesophageal echoes at the heart during the process of a nailing. I recognized other problems, and that would include actually cortical fragments of bone would actually be liberated into the systemic circulation that would go through the heart and cause people issues in the midst of a nailing that we would do. Well, what's interesting is that the original reamers that were used, and we weren't using them at our hospital because Kuncher was on the scene and had given us a set of his reamers, which were very different than the reamers that were existing in most places in the US as well as in Europe. And that is what we call the AO reamers, which we actually still use in the AO courses for nailing sawbones. And that is it was a plunger. And so what ended up happening was the reamer, when you put it down, would fill up immediately with bone. And then instead of the reamer actually preparing the canal, it was actually pushing the medullary contents down the leg and out into the systemic circulation, hence the fat, hence the cortical fragments. And what ended up happening by being developed in the 80s were thinner shafts, deeper flutes, and one-step systems came along only because they thought that would probably decrease the risk of embolization. And if you look here, Jim Green, I've circled it in the bottom, was an engineer who took that and said, why don't I make a reamer that sucks as it reams so that we can just minimize the chance of extravasation? Well, he came up with this fancy device, and initially we thought it would be a good idea, but then a lot of us didn't want to do it because we were worried about what about the reamings that we normally like to push out into the fracture that helps create the healing callus that we would see. And it was expensive. But as many of you know, it's the device we use to harvest bone graft now, and it's been very efficient in that. Around that time, there was also a recognition that the fat didn't just go to the lung. It actually would be small enough that it would go actually into the brain, and actually you would actually see embolic phenomenon, and patients would have a sense of what you get in a head injury because of the fat going into their cerebral circulation. And it's actually extrapolated forward now. There's actually been deaths reported now for retrograde reaming, for example, for a total ankle replacement. When the tourniquet goes down, this embolic phenomenon passes the heart, passes the lung into the brain. Wound care. You know, I didn't, when I was a resident, I told the residents yesterday, I was really good at using a pickup and a staple gun. That's what I learned how to do. Thought I was pretty good at it. And when I went to do my fellowship in Switzerland, I realized not only I should never use a staple gun, but I should learn how to sew. And the closure techniques that I try to teach everybody that I get exposed to really are a testament to one of my mentor's mentor, and that's Martin Allgauer, who was a general surgeon who used a technique where he, instead of using a vertical mattress suture to close the skin, used a subarticular suture, and a wound that you see here on the pretibular area of the leg, which normally if you could not close it without losing the perfusion of the skin would require a free flap. And a wound like this was actually reported in 1963 by Allgauer. It's always misnamed, but an example of closing a wound that in theory would be necrotic with other closure techniques. Fortunate for me, there was a gentleman came to Seattle who could do a free flap and have it work, and that really made a huge difference in managing many osseous injuries that needed free tissue transfer, and we could get reliable coverage for wounds that presented to us, and clearly, as initially was thought to be more ubiquitous for some of the surgeries that you're going to see that we do, but really are relegated to soft tissue deficits the patient comes in with. The VAC didn't exist when I was in Seattle, and I owe my use of it to Larry Webb and Dick Lang, who kept showing me pictures at the academy and the OTA about how they were using this device that was developed at Wake Forest by this plastic surgeon. And I kept telling them, you're crazy, and they kept showing me pictures. And when I brought it to Seattle, I had to tell the rep how to use it. And we would get these bouldering injuries that come in like you see here, and really not an ideal situation, but we were able to do osseous reconstructions of these significant hindfoot injuries, and then use the VAC to manage the soft tissues, ultimately get the soft tissues closed, and then have them be plantigrade with a good foot and ankle, and then finally be able to have them have actually good function without requiring, for example, a free tissue transfer. So that really was, and we use it today. Everybody uses it for many of the open wounds we deal with. And we're in an era now where we can fix almost anything. I mean, what comes down the pike, there is probably someone that's tried to fix it, and we have a lot more tools than we had 35 years ago. And at the same time, also the complexity is worsened, so it actually makes it more of a challenge. And the biggest problem now is the trauma now is of higher velocity, and we are, I'm a baby boomer, and a lot of the people that are now being injured are more elderly. They are going to live as long as their parents. They want to remain active, yet they have osseous injuries that are going to be complex to put together. And the problem in a motor vehicle is that they still haven't figured this out, although Audi and other companies are trying to figure out cars without pedals. What happens to your legs? And you all know, how many of you have been in an auto accident? Any of you been in a head-on collision? Many of you who have been in a head-on collision kind of know that feeling when you're about to crash. And essentially, you're not a race car driver where they're taught to actually pull their legs up when they're in Indianapolis 500. They're taught not to push on the brake. They're taught to pull up. You can't do that. You feel like you have to stop, and so you're pushing down, and then the engine or the floor pan comes up against your feet. And so what ends up happening is the impact of that deceleration acutely is what results in the injuries that we are all seeing now. Very different from what we saw prior to 85. And so these people have, a protracted rehab where many times their disability will be permanent. They maybe can't return to work. Life-altering changes, and that's not going away. This is a worldwide problem. We had to develop newer protocols. We had higher energy injuries, more disturbed soft tissue, so we had to figure out spanning techniques that we never even thought of using with regularity. We had to employ for the femur, the plateau, the penile, and the foot. And we all know, we started spanning the plateau and recognizing, well, that's a way of creating a soft tissue friendly environment for later intervention. Well, we had to just carry that down the leg, not only to the ankle, but even to the foot. So we're going to talk about some specific injuries and just illustrate some of the problems or some of the things that end up presenting themselves on a regular basis to a level one trauma center like yours and like ours. And we'll go from the ankle down. Basic foot anatomy or function. The reason for doing something for all these areas is in the hind foot, you need something that will provide shock absorption, propulsion, and deceleration of your limb when you're walking or running. The midfoot kind of controls the relationship between the hindfoot and the forefoot, so thereby it needs to be a stable area. And the forefoot needs to be a platform upon which you can stand, like a tripod from the heel to the forefoot. And there are basically two major joints, not to be too simplistic, but there are essential joints, meaning joints that if they're damaged or disturbed or fused, the foot doesn't like it or recognizes that and has to alter its function. And that is the ankle, the subtalar, the tailnavicular joint, calcaneal cuboid joint, and the 4-5 cuboid joint. You do something to those joints, the foot is never the same. The non-essential joints, as we call them, are the midfoot joints predominantly. These are syndesmotic joints. They are connected kind of like the tibia and the fibula at the ankle. They are really needed to be stable. They move a little bit, but not a lot. And if you lose those joints, your foot can still function pretty well. So the treatment principles really are in the hindfoot to protect these joints from disturbance or failure. In the midfoot to restore the length and the alignment of both sides, and we've basically divided the midfoot into the medial and lateral columns. And the forefoot is to provide even weight distribution for the foot when you stand or run or ambulate. So starting off with the plafond, you have to realize that the plafond lesions that we see now are completely different than the original thesis that was published by Algar in 1969 and later by Rudy and Algar in 79. The pilon fracture that they saw was kind of like the one on the right there. It's a more torsional-related injury. There wasn't so much disruption of the joint, but there was some, whereas the ones we see now are like on the left, and they are not the same by any stretch, as many of you know. The deceleration that occurs implies that the talus is doing this to the talus is doing this to the end of the tibia, and what has to happen is a reconstruction of that shape. Obviously, higher energy injuries do worse. I mean, I don't know how you can do this and still survive, but I had to take care of this guy. I couldn't believe it. He put his tibia through his foot. And historically, when you look at these injuries, Rudy and Algar, when they first talked about this, when Rudy was an Oberarzt, I think they were seeing an injury that no one was really dreaming of operating on, and they were good surgeons. They were general surgeons, knew how to use a knife, and they actually published pretty good results. Unfortunately, us in North America, as well as other areas of the world, really didn't do too well, and we actually had bad results, and we basically then castigated them and saying, well, it's because they're not accurate in their reporting, because we as good surgeons can't do what they're doing. Well, it was us. And there is some nihilism that's out there, and there's still nihilism exists even more today, is that these injuries do poorly, and success would be if I'm involved, if there's no acute complications that I can be blamed for, i.e. a wound complication, an amputation, something that potentially I was involved in creating. And I would submit to you, I think the big thing you should look at it is, what about the reduction, and what about your ability to attain and maintain a reduction? Because that's really the answer you should be giving, rather than saying it's impossible. Because of the compromise of function. That is, if you do an arthrodesis, you do a total ankle arthroplasty, or an amputation, that patient's function is never the same as it would be with their native ankle that would work. And if you look at these are really not good salvage opportunities for patients. You tell them that they're going to be fine, but they're not fine. And for example, let's say if you just do an ankle arthrodesis in a perfect position, this is what happens. This is an ankle arthrodesis that was done on an 18-year-old girl at 30 years old. She comes back, and she can't really do anything except ride her horse because she doesn't want to walk, because her subtalar joint is arthritic. And what do you do with the subtalar joint? You fuse it. Then what do? It's because progressively stiffer, it's different. And then they want an amputation because their foot doesn't really work very well. So it's all about the initial event. And so the protocols that were developed in this country are a direct response to recognizing that in Switzerland they were doing both bones in one sitting. And I remember distinctly as a fellow in 1984 watching Tom Rudy, or helping Tom Rudy, fix a pilon fracture, and the intensity that occurred in his voice and his mannerisms as he was trying to put an ankle or pilon fracture that was really not complicated compared to what we see now in the tourniquet time, because he had to fix the fibula already and he was trying to fix the tibia. And we soon realized that was the problem. We can't do them both at the same time. And so we would do these devices where we put a frame on, realign the hindfoot starting with the fibula, because that sort of gives you a position of where the talus goes. And then ultimately when you do an osseous reconstruction of the joint, it has to be with as perfect an articular reduction as you can get in a safe manner that you can close the wound. Then this came along. And this is the new age pilon, which we never saw until now, the airbag. And that is where you're in a crash and you're plantar flexing your foot, and instead of just axially loading through into your tibia, you extrude out the front of your leg. And that causes a crush in the front, which is very difficult to address, and the soft tissues are always problematic. And big issue as to how am I going to get the articular surface down, rotated, congruent with the talus under the tibia. If I can do that, then the patient has the best chance of getting a reasonable ankle function. And that is a really big problem, a big challenge. And what you then learn when you start looking at reconstructions of ankles is that people have different profound architecture, especially in the sagittal plane, because the front of the tibia is like a roof for the talus. And if the tibia doesn't have a good roof reestablished, the talus will come out the front again, just like it did in the initial injury. And there were times where people would try to send us patients by saying, hey, you know, we have a PL fracture, we don't really know how to fix that, but we'll fix the fibula for you. We've now gone to the point where we're saying, don't do anything, because they not only can't fix the fibula, as you can see here, this is malaligned, so it's invarus, the talus can't be established where it should go. They don't know how to put a frame on at other institutions, so we don't even ask them to put frames on. That's within 30 miles of our institution. So those scenarios, we wrote a paper on this, and everybody at level 1 centers around the country has corroborated that you'd want to be treating it from the get-go, because our complication rate triples when somebody's already taken a swing at something that you ultimately are going to be caring for. So this is an example of that, and doing a reconstruction later is predicated on the timing of that intervention. Avoid definitive treatment. That's another disaster. Here's a young lady who was skiing, who had a torsional injury, like Rudy and Algar spoke about, had a torsional injury, and this was fixed, the 9 injury. And you can see that there's a lot of metal in that limb. And unfortunately, when she came to our hospital, she presented with a big hole in her leg. And at 18, basically it was an amputation or a limb salvage procedure. Fortunately, Doug Handel could cover this, and then I could refix the pilon under that hunk of gracilis muscle. But that's something that you should never have to be able to do, because it should be treated in a process that wouldn't require that. Moving down to the talus, you know, I as a foot person now, predominantly, this is really the center of our world. This is the center of the universe, meaning all the foot function is predicated around moving around the talus, whether it's the talar head, the lateral process, the posterior process, the neck, or the body. And the rationale for treating this is pivotal on hindfoot and Chopard's joint. Same problem. The axial load will cause some sort of peritalar injury, either a lateral or medial dislocation with a fracture, and it always goes through the subtalar joint. And so what ends up happening is you'll have these wounds that are literally torn by virtue of the disruption, and then you have an osseous injury underneath it with which you have to address. And you can see, for example, on this patient, it was torn actually above his ankle, but we could, through his open wound, we could see the talus and manage it, although separately. Peripheral talus lesions really imply that if you can reconstruct the peripheral aspects of the talus, that will predicate a return of function to Chopard's joint and to the subtalar joint, and specifically the posterior facet. And it sounds crazy to do this, but think of the alternatives. There is no talonavicular prosthesis. There is no subtalar prosthesis. And so all you can do if this fails is a fusion. There was a paper a few years ago talking about how well subtalar dislocations do. I'd submit to you they don't do well. In fact, this is a woman who came from Alaska who, after 3 months, couldn't walk on her foot, and this is the debris I took out of her subtalar joint that was never looked at, and she couldn't put her foot on the ground because there was so much debris that had congealed and then was like sandpaper in her subtalar joint. So I would submit to you that perhaps you should be thinking about doing that acutely. These peripheral lesions, they defy description, but they all involve joints that if you don't put them together, they won't work. This is an example of a talar head fracture that involves the talonavicular joint, an injury to the subtalar joint via the lateral process, and if you fix all of these, at least they can have something to spin around with their foot if you can reconstruct the talus. The high energy injuries of the talus are pivotal in the sense that the injury causes many times the perfusion deficit that these bones sustain. But when you are surgically managing them, you ideally want to put a reconstruction so that, once again, the joints can move around the talus. And Keith Mayer actually wrote a monograph in 1987 talking about the dual approaches, but at that time people were only doing medial approaches for the most part, and we were trying to incite people to look on both sides, and this is an example of the surgical approach that he would advocate is going medially, which is what everybody was doing. The problem is if you don't do a lateral approach in conjunction with your medial approach, you get this scenario. This is a Hawkins 2 variant, and you can see that the subtalar joint's dislocated, and you can see all the implants are medial because there was only a medial approach. And this patient came to my clinic 3 months later, couldn't put his foot down on the ground, and this is why. There was debris in the subtalar joint that never was addressed. The neck was probably not anatomically reduced because they didn't look from the lateral side, and so this rapidly goes on to subtalar arthritis. And that's the big bugaboo with talus fractures in general. So that's why the interlateral approach is so important and learning how to do it. I think the big thing is when you're doing dual approaches, you can see what you need to see from each vantage point, trying not to disturb what's in between on the dorsal aspect of the neck, and doing a reconstruction. Unfortunately, when things spit out the back, you have to figure out alternative methods of treating it, but the whole rationale is to reconstruct the morphology of the bone so that the joints can move. That includes sometimes a median malleolar osteotomy, which is involved really with specific body involvement, but that's actually not that common. But what is more common now is there's so much collapse of the talar neck. In many instances, screws alone will not be enough, and you need to reestablish the morphology by using sometimes dual distractors, as you can see here, to establish the neck length, and then use plates to reconstruct the shape so that the foot can, the shoulder arch joint can work in the front and the behind subtalar joint can work. The peripheral reconstruction, the critical thing is that all of these are imperative in terms of, think of the alternatives. If they develop arthrosis in any of these joints, there's not really much to do. Then this came along. I remember this patient when he came in. He had fallen off a roof, but now 99% of these are motor vehicular right foot with a subtalar dislocation, and it's a posteromedial talar body fracture. It's behind the median malleolus, so you don't want to do a median malleolar osteotomy. You need to go behind that. And the first time I saw that, I really had no idea what to do. But now I figured out, and I've got an arthritic neck, so I used to try to do this with the patient supine, but as you look, you really need to see in the back, and you need distraction to do that. This is an example of what that lesion looks like on a CT scan. So you can see if you look where it is, it's posteromedial, so it's on the medial side, and if it's not supported, then the posterior facet of the calcaneus will fall, and the patient will get a varus deformity and arthrosis very rapidly. And so I've gone to the point where now I do this prone, and you need distraction to allow you to look in the joint. And when you do that dorsal approach, this is what you see. You see the FHL muscle belly here, and you go through it, and by retracting it, you can then see into the joint, both the tibial-talar joint and the subtalar joint, and then provide buttress fixation of that fragment or fragments. Is it really worth fixing a talus fracture? Well, we did a study about 15 years ago on a, is it 15? It's around 17. So this is a guy who came in on a Sunday, and he had this neck body fracture with a splits on the coronal plane into his joint. We called these people up 10 years later to see how they were doing, because we had fellows look at the x-rays and predict what the outcome would be based on the osseous injury and the CT scan. So the assumption was that they were going to both be, they're going to all be surgically treated with dual approaches and whatever it took to fix the fracture. But could we predict the outcome? So when you look at this, all you can think of is this is going to be terrible. And so fortunately, this is 1991 when it occurred. This is what I did all day Sunday, and to me now it looks macro, looks like huge, the screws look huge, but I had to do an osteotomy to fix it, and I forgot all about the patient. And when we called these people up 10 years later, and actually now it's 20, this is what his x-ray looks like. And the only reason I called him was because the radiology department charged the patients for the x-rays, and we had made a deal that we could get x-rays without incurring a charge. So this patient came in for the good of the order, got an x-ray, And then he got a bill for $300, and he called him and said, hey, I came back, and what are you doing? You're charging me for just, and so anyway, I tried to make that go away, and I did. But then I asked him, how are you doing? And Daryl will appreciate this. He said, you know, Doc, this is my good foot. Because when I fell, I had an L1 burst fracture, and my other leg doesn't work. I need a brace. This is the leg I do everything with. I depend on this leg because my other leg doesn't have the function that this one does to do what I want to do. So that was kind of corroborating in my mind, maybe that we were doing the right thing. This is a fracture I never saw treated as a resident. Never. It was essentially an injury that I was told they all did great. And this is just a video clip that one of our fellows did of the injury occurring. So it's once again an axial lobe, but it goes through the subtalar joint. Everything crushes around the talus, and that's where the joint many times goes through the bottom of the foot. And when you look at when you compare the other side, because when I was told by Ted to fix this, I didn't really know how to fix it because nobody had ever fixed it before in a way that you could get the shape back. But he said, look, I can tell you if you don't do something, this is what you see. And then he had a whole foot clinic of non-operative treated calcaneus fractures. 40% of his patients, new patients, were non-operative treated calcaneus fractures. And I just happened to be sitting there seeing what he was seeing in clinic, and he turned to me and said, hey, you know, look at this. This is, and then you say something expletive deleted. Figure out how to fix this. Because look what we could do. Now we can do a crappy operation for something that should be fixed. We fix every other articulated fracture. Why don't we fix this? Oh, great. Anyway, so it's a complicated problem, and those of you who have treated them, you know it is. There are a lot of factors to deal with. The patients have issues, they all do. And then open fractures are really even more concerning because they have a medial open wound almost all, and how to manage those. And early on, we were trying to manage the open wounds without doing something except for washing out the wound, but not really doing anything. We've evolved now for open fractures, we actually put a frame on like you do for a pilon fracture to realign the limb, close the wound so we cannot deal with the medial wound anymore and do it from the lateral approach. This is an example of realigning the hindfoot so that the shape is back. And now we've extrapolated that to closed fractures because many closed fractures do better when you realign them acutely. And so you want to get good x-rays. I had no idea what I was doing when I first started. Fortunately for me, one of my partners was Keith Mayo, who had done a fellowship with Emile Letournel. He'd come back to Seattle. We were practicing together, and Emile came to Seattle to see Keith because Keith was involved with all the lead lines in Letournel's book, and he came to visit for a week, and he likes the calcaneus. So we had this patient that came in, and he said, yeah, this is a cool little bone. It's like the acetabulum pedis. It's just like the acetabulum in the foot. And let me show you what we're doing in France. So he showed us, and then we tried to imitate what he was doing. And the whole point was to try to reconstruct everything. But at that time, we were doing Coker approaches, as was he. This is around 84, 85. He had done them that way for a while. And there's a book that he has that he's shown pictures of it. But the problem is we were doing it, we tried to do it that way. And we realized this was not good because we were looking at the tendons, we were looking at the nerve, and if we could somehow not damage them in the process of doing the operation, they clearly scarred in with the subsequent incision healing. So we had to bite the bullet and just do something dramatic, which initially everybody thought I was crazy. I said, I don't know what you think you're going to do. This is not going to work. And anyway, we tried it, and obviously it does work. But you have to basically elevate this whole lateral mass so that you can essentially access the subtalar joint and then indirectly reduce the tuberosity. Borelli then years later corroborated that there is an artery that actually is what's perfusing this flap, and if you don't damage it, you'll likely be able to manage the patient successfully. But you gotta not just reduce the posterior facet, you gotta fix the front and the back, and everybody at that time was just trying to fix the posterior facet, but that doesn't really relegate to very good foot function. So you really have to work from the very front, and you need to see. There's a hole. You can't see. And those of you who use a headlight really learn to basically do everything with a headlight after a while because you can see so well. And this is like from Finding Nemo, you know, that the light that you see I've now gone to a point where I'm using an LED because the nurses don't want to be attached to a box that they have to follow around my body with the box to allow me to not contaminate the wound. And this has really enabled us to see, and then indirectly you reduce the tuberosity. So here's an example of, if you don't do everything right, here's the tuberosity, that's under-reduced. It's still not out to length and medially translated, and that patient won't do well. I've made that mistake. And so the defects, when you do a reconstruction, 100% of them have a defect. It's sometimes cavernous, and to do a realignment without putting something to fill that void is difficult. This is a classic example of a joint depression injury where that posterior facet fragment really is not viable. I mean, you take it out of the leg sometime and put it back in, so it has to be reperfused. And so when you see an injury like this, a joint depression injury, everything's collapsed, the talus is flat, you need to lift it back up and you need to restore the shape. And you can see that if you just tried to reduce the posterior facet, the front's wrong, and you can't reduce the posterior facet when the middle of it is still sunken into the body of the heel. So to realign it requires a reconstruction of each of the fragments in a way that when you put the implants, these are K-wires, that you can then put the plate on without having to remove the wires. So you learn how to put the wires in the periphery, and then you compress, because you want to get metaphyseal width back, or narrowness back, I should say. Many of the screws become too long, and so when you're done, you get the shape back that corroborates what the other foot looks like. And everybody's foot's different. What about locked implants? Do we need locked implants? Well, at first I said you never need a locked implant, you can just put them back together. Now I wouldn't say that, because some of these injuries that come along demand something that allows you to get enough stability that will last long enough so the revascularization can occur. This is an older device, bigger, more massive. There is a newer locked implant. This is an example of what that looks like. This is a lesion that in some institutions a third would be amputated, because these are open. These are plantarly open wounds because the talus goes through the bottom of the foot. And this is an example where as it is injured, the navicular is also broken. So you have to address the navicular as well as the calcaneus. You can see the marginal impaction of the plantar aspect of the navicular. If you don't restore that, the talus will fall back down through. So initially, just like dislocations of other parts of the body, you reduce it. Then you start off, you fix the navicular, get the shape of the navicular back, and then when you put the calcaneus back together, you try to match their other side. Here's an example of what it looks like. And here he is at a year. Here he is at 2 years. He's a roofer, actually, interestingly. He's back to roofing. And that's all he knows, and he can do that. But I know if we hadn't been able to do this, he couldn't do that with a subtalar fusion. And he's able to do what his avocation is. And fortunately for us, we have some things coming down I'll show you. Closing the wound, it's just a matter of knowing how to get the periosteum closed and closing the skin once again with alveolar closure. And then the most important thing is to be encouraging to the patient to say, look, your foot's going to hurt for a bit, but the more you move it, the better it'll feel, the better your function will be when it's time to walk. So the more they're able to do that, when they are able to walk, they have the best subtalar function. You don't put them in a cast. We looked at a series, took a long time to get this published, but we looked at a series, sequential series, and you can do this, and the traumatologists that you have here can do this operation, and they are doing it. Then all of a sudden you get these challenges. You think you've got it down, you know what you're doing, and then this comes in. This is a lady who came from Idaho, and she was in a head-on collision, not her fault. That's her car. As you can see, it's on the right side of the road. So she was on the right lane of the highway, and she did, unfortunately, in her situation, the 3-hospital transfer. 2 hospitals said she needed bilateral. These are bilaterally open. These are bilateral injuries. Bilateral talus, bilateral calcaneus, bilaterally open. She needed bilateral below-knee amputations, and she said, "I can feel my feet. You're going to cut them off?" And so, anyway, we put them together. And she calls me every 6 months to tell me that, life's okay. Her biggest problem, her eyeball, because she had an osseous injury. She fractured her orbit, and it wasn't really well treated. And she's a teacher, and everybody looks at her. But she can walk and do everything she wants to do, but her eye is still one of her major complaints. Then this comes along. You figure, okay, that's where everything's there. This is what we get now from another hospital. This is the acute injury, and there is no posterior facet, because the medial wound it was sitting there and they threw it away. So then it comes to us and we have this. So you have a big hole. So what do? Well, since we had some experience with the previous things, we realign the foot. There's a big defect. You can see the hole. It's not small. Get the shape back. There's a medial wound, remember? And then later on, we do a reconstruction, in this case, to provide stability in the area where there was no posterior set. We started to use tantalum to reestablish the shape and hold the talus up. And this gives you an idea of what their functional recovery can be like. That's something that, you know, if I was delivered this 25 years ago, I wouldn't have been able to figure this out. But as you get more complicated things, you have to become more innovative. And we all talk to each other as traumatologists around the country. Anything new? Got anything figured out? Because that's how you get an evolution of our skills. Same thing with show parts injuries. You know, we talked about navicular fractures in the 80s. They're not like this anymore. I mean, they're impacted, but in many cases, that's a relatively easy injury. What we see now is these complicated injuries where the talus is sitting on the cuneiforms, and you've got to bring the navicular back into its right architecture so that show parts joint works. And many times it's associated with a cuboid fracture. So that's a very common scenario. And then when you're fixing the lateral side, it's all about getting the calcaneal cuboid joint realigned, many times requiring a distractor. What about the midfoot? Everybody's really into, like, what do we do with the midfoot? There's not so much magic about the midfoot as long as you can provide stability. And this is a good sort of take on this. Is a woman who came in, head-on collision. She came in, her foot was white. She had no circulation beyond her TMT joints because she shifted everything over one joint. And so we, just by pulling on her, we distracted, realigned her, did a fasciotomy of her foot. And then this is what it looked like acutely. These are what the frames look like to hold the foot in the right shape until we could intervene. The disruption is always obvious. It's not really difficult to ascertain it. And we start from medial to go lateral. So this is what it's like. So you put the syndesmotic joints back together, and you get the articular surfaces that need to move back together. And I forgot about this patient. 15 years later, since I'm in Seattle, she's still in Seattle, another head-on collision. And she comes in, and you can see her x-ray from the initial event and 15 years before. Hasn't really changed much. She actually just came in to check and see if it was okay because she'd done the same things she'd done 15 years before, but hadn't injured it to the point where she had from the prior injury. If they're involving metatarsal fractures, you can't pin those. You need to plate those. You need to get stability so that there's a tripod effect. And then you got to be careful with those movements. It's like anything else. Once you learn how to do this carefully. But when you get a foot like this is a foot in jeopardy. This is a patient who's in head-on collision. It's her left foot, but she broke both of her wrists. The airbag went off. She broke both her wrists. She came from another hospital. Somebody put her in a cast. And when you look at this x-ray, and then you look at this osseous injury, you realize there's an unreduced dislocation of the navicular. And that was actually her biggest problem because you see where it is. It's sitting on the top of the foot. And so we had to put a frame on to realign it to deal with the blistering. And that lesion took a long time to heal, was nearly full thickness, ultimately could be reconstructed. And when we realigned her foot, the idea was, the most challenging was actually fixing her head fractures of 2, 3, and 4, because there's really nothing to fix with, but to reestablish. And amazingly, she even got her intrinsics back to her foot, given the shape of her foot. Forefoot injuries, really the biggest issue is, once again, realigning the limb so that you can have the tripod effect of your forefoot for push-off. If you look at the literature, not very good if you don't do a good job, because these people really don't do well with that, and it hasn't really changed much. If you look at the sickness impact profile, which basically tells people, tells us how they're doing, they don't do well. And so you end up using their wire fixation, plate fixation, then get stability of the medial column. But even if you do a good job, the foot, long after the long bone injuries have healed, is still a problem. So I'm going to finish by just letting you know that people, and they make fun of me, and I'm happy that you made fun of, that operating takes a while. It takes a long time. But we have good anesthesia today, and when you do an articular reconstruction of something complex, you cannot do it in an hour. I mean, I'm lucky if I can get the reconstruction of the joint we're working on in 2 hours, and then it's subsequently fixing it and then closing the wound. You only get one chance, because the second chance that comes when somebody does something not ideally, it's always predicated with a compromise. It is difficult. It takes time, but the patients will tell you it's worth it, and that's what you have to realize is we're not doing it for us. It's not about how great you are. It's all about how the patients respond and how they can move on with their life. And I will finish because every time I talk about this now, I get kind of emotional, but my dad is the guy on the left. He never cut me any slack as a kid, and he always pushed me, and he always pushed the medical students that he was dealing with and in academic medicine. And I was fortunate enough, because I met Tom Rudy when I was a fellow, who's in the foreground. His mentor is Martin Algar in the back, and this is a picture I got when they were all visiting us in San Diego. And each of those people has been pivotal in my life, and I think without them, I wouldn't be where I am. But I have to give special admonishments to Ted Hansen on the right, who really, he's a person that you can always talk to, and he taught me early on it's all about the patients, and if you do the right thing, they'll come back and thank you. And Emil Turnell, who was very similar in that regard for his pelvic and acetabulum patient, but he treated a myriad of conditions that many of you don't even know about, but he was an amazing surgeon and a great person. Those people in my life really shaped me, and I give them credit every time I can. You're lucky here because you have mentors too, and I think it's important to recognize that those people, Thomas, you've been here 18 years now, so he's not a newbie, and the important thing is that his experience is 18 years of experience, and that's really important to try to get as much out of him while you're training as you can, because once you leave, then it's going to be you. And those of us that have a mentor, if they're still alive, I give them homage all the time because they're the ones that sort of helped us in this path. So in summary, survival is really improved. Injuries are more complicated. The results are compromised. We all know about that. The numbers are increasing and the complexity is increasing, but the importance is increasing because this is your dilemma. Which road do you take? And that is a problem because there is a lot of pressure to take the road to the left. And that is a problem because that's something you have to fight for rather than let someone tell you what to do. You have to do what you think is right. And I think that's very important because it's very easy to take the road to the left. This is the disturbing part, but I'll end up hopefully with something positive. This is the DALY score. It's called the Disability Adjusted Life Year Score. It's essentially a worldwide scoring system of what society has to deal with. And if you look at 1990, the problems were diarrheal diseases, lower respiratory infections. It's predicted in 2 years that the top 3 diagnoses will be ischemic heart disease, probably the stress of living in this world. 2, unipolar major depression, also probably from the stress of dealing with life. But the third, and this is a worldwide, this is not US, this is Africa, India, China, worldwide, it's the sequelae of road traffic accidents, the things that I've been showing you for the last hour. And that is really what we're up against because it's going to be moving to the top of the pile. So to finish, we can't do anything about the injury, hopefully we can. Can't do anything about we can do something about the reduction. We can hopefully facilitate the ability for rehabilitation. There is an adjunct that has come down the pike that I didn't have 10 years ago, and it's evolved. Originally, so sometimes war brings good things to pass for patients, and this is a prosthetist from Seattle. When patients were coming from Afghanistan and Iraq, they would come to Langstuhl and then to Seattle. All of them had foot and ankle injuries. All of them had head injuries of varying degrees. They would go to Texas to rehabilitate, and then they all would want to go back to their unit. But like an airline pilot or a policeman or fireman, you have to pass a physical. And so they couldn't pass the physical. So they'd say, well, what can I do? I want to go back. I don't want to retire. Well, you could have an amputation. So they would say, okay, do it. So sometimes 2 amputations and 2 prostheses to be able to get back to their unit. This prosthetist saw them coming by Lewis McCorders, a base near Seattle. Said, well, if you're going to do an amputation, do it here, because I make prostheses. And, oh no, they got to go to Texas. That's where we go. We all go to the Center for the Intrepid. He moved to Texas with his family, saw these feet that had come by his institution, and said, well, the foot doesn't look that bad. Do we really need to cut it off? And so he got some seed money from the military to develop a device, which he nicknamed the IDEO, Intrepid Dynamic Exoskeletal Orthosis. And the amputation rate in the military went down by 90+%. There was a very vexing period where somebody who just had a peroneal amputation looked over and saw a guy with a similar set of injuries that got a brace and was back to his unit while he was still struggling to learn how to use a prosthesis. That has evolved. That was okay. Now we've evolved to an evolution of Ryan's initial concept, which now we're extrapolating. Workman's Comp is paying for this. The Blues are paying for it because it facilitates patients to get back function that a hindfoot or midfoot or forefoot injury doesn't let them do. It's interesting because it's modular. The struts are of 9 different stiffnesses, so it builds in the flex of your limb. This is a dramatic example of transformation of function. This patient, had a hindfoot amputation and wanted an amputation.
I just turned it off. Just kill the mic. Just turn it off. Just turn it off.
So this guy wanted an amputation. You can actually see where he had old external fixer pin tracks. He wanted an amputation, but we evolved, and Dave said, look, we just got to make something funny for your foot because you don't have a foot, so we got to hold this back into this brace. But when you see what happens to him after he's fitted, this is him with this brace on, and this is becoming the norm. So this is an example of him running, and you can see he has no antalgia. He can spend a symmetrical same time on his right as he is on his left. He's actually doing a selfie of him running, as you can see. And he basically comes back, and I see more tears in my clinic with this device in the last 5 years than with, they obviously are appreciative of what you do, but when they end up with what they have, and then you say, do you want to go back to work? Do you want to do your old job? Do you want to run again? And when you bring up that question to them, they've already said, I'm never going to be able to do that again. And when you give them that chance, and then when they see this, there's more emotion than I can tell you. And it's, we have a former fellow who, now I'm going to end with this because he said, Steve, you shouldn't be showing this. I said, why not? This is great for people to be able to function better and to do their activities, do sport, do work, do activities that they couldn't do. Yeah, but Steve, if you get this brace, people are going to take the road to the left, that they're going to do a shitty job, and they're just going to give them a brace. And that's not the whole thing I'm trying to get across. You've got to get everything reestablished morphologically right to get the best recovery. This just facilitates that recovery. And so that's why I think it's important to do all the things before giving someone this brace. So, thanks for your time. I appreciate your time.
Whoever can, stick around. Steve's enthusiasm is famous for running into the second hour. Whoever wants to stick around for some questions and answers, who has time to, thank you. We have a couple of small tokens of our appreciation here from the youth. We're not going to make you put the hat on, but we will later. So thank you again. Your generosity with your time is the most inspirational, and you spun through a bunch of x-rays that I would be bragging about for 10 years without any comment. It is an inspiration to all of us to do better. Any questions? Just drinking it in. Just
Steve,
Yeah.
has the cost of that IDEO brace come down?
Oh, yeah. So, Ryan, who is a friend of mine, is now back from the military. So he didn't want to live in San Antonio. He moved back to Seattle. But he is still getting all of the military people. And his device, which I will show you if whoever sticks around, I'll show you an example of his brace, which is similar but different. He charges $15,000 for that brace. This brace is less than $5,000. So Workman's Comp is happy to pay for that, because if you look at the cost of some of the other devices we give for the hindfoot, the Arizona brace, or some of these other devices which are in the thousands, never can restore the function that these patients get with this device. They're happy to pay for it. And the fortunate thing is it's modular. So it's adjustable. Patients can, as their foot changes shape, you don't have to make a whole new brace. Whereas, and those of you who are snowboarders, you probably recognize that the device, as you put it on, has got like a snowboard ratchet device, which actually is probably a little better than the original version. But you have to give credit to Ryan, who came up with the original idea, because he saw these feet and ankles that he said, why do we have to, because he's a craftsman, and he came up with the idea, and ironically he patented it. And when he moved back to Seattle, and he's no longer in the military, he gave the patent to the military. So ironically, he has to pay the military for something he invented. This is now an extrapolation of that. This new brace is an extrapolation of that. It goes in ski boots. I have actually 4 patients now that put this in, that have ipsilateral ankle and subtalar arthritis, that they put it into their ski boot, because you just take the shell out, it slides in, and they can ski. So it's by leaps and bounds evolving, which is really kind of cool, because you're seeing people seeing what's available and then building on it. And he's all about, so, and I told Thomas, he is the kind of guy that he's now, whenever I call Dave, he's never in town, because he's in Baltimore, in Pennsylvania, in Florida, talking about this, because he's not about, for him, he's trying to get the local orthotist prosthetists making this so that it can be ubiquitous, not just isolated. And that's really, you'll see it, you'll watch, in the next 5 years, it's going to really take off.
Any other
questions?
All right, the residents are going to stick around for the second hour. Steve, you're going to talk about what?
What is it again?
Things you wish you knew at the beginning.
Yes, what I wish I knew before I started.